Hello everyone, welcome to HIM 216. This will be your final lecture for Chapter 9. And in this lecture we are going to finish up the coding guidelines for Chapter 9 and then go over your homework assignment. In your textbook, turn to page 187. And we're looking at the guidelines for methicillin-resistant Staphylococcal aureus conditions. There are some combination codes for this organism and different disease processes. For instance, if we look at pneumonia and if we look at pneumonia, come on, wake up. Staphylococcal aureus methicillin-resistant MRSA. The code is J15.212. And as we look at this code, we can see that this is pneumonia due to methicillin-resistant Staphylococcus aureus. So this is the code we use. It's a combination code. In addition to this, we do not use the code in diseases classified elsewhere. B95.8. It would be inappropriate to, or B95.62. It would be inappropriate to assign that code because the fact that this is an MRSA pneumonia is included in the description of that code. And we would also not assign a code for an organism that is resistant to penicillin, and we can do that. We can go to resistance, organisms to drug penicillin, Z16.11. We also would not assign that code because that resistance is included in that combination code. If, however, we have documentation of an infection due to MRSA and there is not a combination code, then we are going to use B95.62 to indicate that the organism that is growing is actually Staph aureus and that it is resistant to methicillin. It's a penicillin resistant strain of Staph aureus. So if the description of the infection doesn't include the fact that it's an MRSA organism, we're going to add the code of B95.62. But we would not assign a code from Z16.11 because that is actually included in the description of B95.62. Now, there are some people that actually carry it around with them, MRSA, MSSA, all the time. And I have been told that if you did a nose swab on any healthcare worker, that you would find that they were actually a carrier of MRSA. And in fact, many people get MRSA while they're in the hospital because it is that kind of disease, and people carry it around. I remember that we were having a problem with, when I worked at a hospital in Alabama, we were having a problem that all of our carotid endarterectomy patients were getting a post-op wound infection, and so they cultured everything, all the equipment, the surgery room. Then they finally started on the employees, and what they found was that the surgeon, who actually came from another larger town to perform these procedures at our small hospital, when he came, he brought with him a surgeon assistant, and the surgeon's assistant cultured positive for the organism that the patients were getting. So it's just very possible. So MRSA, if a patient is a carrier, will code to Z22.322. Carrier of infectious disease is the category, and you can see there are other diseases in here: typhoid, diphtheria, strep B, different hepatitises. So other carrier codes as well. Now on page 188 it tells you that a patient can have a current active infection and be a carrier, and you can actually apply both of those codes. In looking through this chapter, most of this coding is fairly straightforward. You need to understand the guidelines, the very chapter-specific guidelines. You need to be cautious not to code sequela of these infectious disease and parasites as though they are active diseases. So we do have codes for sequela of TB, polio, leprosy, and other unspecified diseases. So be very careful with that. Don't assign a sequela when in fact you have an acute infection, or vice versa. On page 192, let me see if I can put in MAC. No, I cannot. So Mycobacterium avium complex. So if I go to Mycobacterium avium intracellular complex, I'll find A31.0. It says let's see if I put in I can't put in complex and go the other way, so I do have to put in bacterium and then avium. Mycobacterium avium intracellular, and we'll see that this codes to A31.0, pulmonary microbacterial infection. There's also DMAC, disseminated Mycobacterium avium infection, and that codes to A31.2. Be sure to read the guidelines on sepsis. When we're looking on this page, come down to the middle where it talks about sequencing of codes for sepsis with a localized infection. It says assign the code for the underlying systemic infection. Okay, this is going to be like the A40 or category A40 or A41 code. Assign the code for the localized infection. This is going to be like pneumonia, cellulitis, urinary tract infection. Assign the code for severe sepsis, and this is going to be R65.2 to 1, R65.20 actually. If it's severe sepsis with shock, R65.21. And then organ dysfunction. So any organ dysfunction that is documented as being due to the sepsis, you will also have a code for that. The other codes throughout here are pretty straightforward. We went over HIV on page 199. You're responsible for the content of this chapter and being able to code from this chapter, so be sure to look through, read through the rest of these and go through the examples. Exercise 9.6. Nope, I'm not going to give you any questions for this lecture. I suspect you'll listen to it just to hear the information about the homework. On page 204 and 205, are actually the Z codes that are applicable to this chapter. You need to look through those. You'll see a lot of encounter for screenings, resistance to, contact with. So if someone thinks that they have had contact with or been exposed to some of the different diseases from this chapter, there are specific codes for those. On page 206 are all the carrier codes, and then there are some family history and personal history codes as well. When we're looking at procedures, there aren't any specific procedures for this chapter, but there are some of the procedures definitely apply. A patient has an abscess with an organism, incision and drainage possibly. And then on page 207, these are some of the complications and comorbidities that could impact a DRG weight, increasing that weight, thus increasing reimbursement. So keep those in mind. And then for your homework, the chapter review is on page 208, and you're answering the odd numbered coding questions 1 through 19. And I will tell you that for 1, 3, and 5, those are each one code. For number 7, there are 2 codes. One of these codes is a procedure code for isolation. 9, 11, 13, and 15 you have one code for each of those. 17 and 19, there are 2 codes for those. And number 19 is an HIV situation, HIV with Burkitt's lymphoma. You're going to refer back to that list that's on page, which page was it on? I thought it was 199. That has the listing. It was page 200. The AIDS defining conditions that are on page 200. Then you also have a workbook assignment. Now for the workbook assignment, there are 6 glossary definitions. Answer those. And then for coding, you're going to be answering the odd number questions 1 through 23. And for 1, 3, 5, 7, 9, and 11, there is 1 code. Um, 13 has 2 codes. Now, this is PCP pneumonia in an immunocompromised patient. This patient does not have AIDS. So be careful when you're coding that one. And then 15, 17, 19, 21, and 23 all have 1 code. Keep in mind that if you can't find, for these you're going to look up infection, typically for these codes. And you're going to remember that these are going to be typically, with the exception of 21, these are going to be B codes. And if you can't find the specific organism, remember to think about specified NEC. Okay? And then you are also going to complete case scenario 1 and case scenario 5. And let's look at these. For number 1, the patient's admitted to the hospital with cough and malaise. They have a history of AIDS. So that means they have AIDS. You don't have a history of AIDS. And they were previously in the hospital with candidial esophagitis, and now they determined that the patient has pneumonia. Now, this is not a recurrent pneumonia. So you have to carefully determine whether or not this pneumonia is actually related to their AIDS. And I will tell you that unless it becomes recurrent, and this doesn't say it's recurrent, the pneumonia may not be related to the AIDS. Then for number 5, and there are 2 codes for number 1. For number 5, this patient has been HIV positive and they're coming in with fever, malaise, and cough. They suspect that the patient has pneumocystis coronae pneumonia, but they actually find out that the patient really has mononucleosis. So in this example, the patient's HIV positive. If they did have PCP pneumonia, they wouldn't be HIV positive anymore, they'd have AIDS, but they're not. They don't have PCP pneumonia. What they have is mono. Is mono an AIDS-defining illness? That determines whether or not you're going to assign the code for HIV positive or for AIDS. And if it's not an AIDS-defining illness, then you can't assign the code for AIDS. So in this example, you're going to want to determine the condition that occasioned the admission, and you will have 2 codes for number 5. If you have any questions related to these, be sure and let me know, and I'll be happy to answer your questions. And that will conclude this final lecture for Chapter 9.